Great. So hopefully, perfect. Thanks. Everyone can hear me. Hopefully everyone's doing well. My name is Shawn Gargoum, and I am your first panelist for the BISC concussion series. We are presenting from our clinic, Complex Injury Rehab, and we are located in Pickering, just in the East End. I've done this talk for the past 3 years, I believe, and this year is a little bit different, obviously, with the everything being virtual and webinar based. Hopefully we can get all the information across. I'm sure it will come across pretty well, and then we can hopefully have a bit of a question and answer period at the end of the presentation. There is a Q&A box at the bottom of your screen, or if you type in the chat, then I can have a look and see. All right, I'm going to share my screen here. All right, so I'll get into my background a little bit. First, let's get through kind of the more logistical stuff here. So this concussion series was brought about for a few different reasons. So we work hand in hand with BIST, and we have for a few years, and we maintain a pretty good relationship with them, and we wanted to give their members a little bit more of the evidence-based information on concussion. Okay, so you can see by the aim of the series there that number one is evidence-based information. The concussion world is pretty wide and varied. Lots of misinformation out there, lots of different opinions and thoughts on concussion. And I think personally, I am very grounded in science and research, and I think that is what we can rely on best, because you know, the work has gone into it to provide some clarity on the actual questions in hand. Now, it's important to remember that research doesn't always cover every single aspect or cover all the specifics of care and of, you know, patient-based questions, but I think, you know, above all else, it gives us a general idea for ethical-based practice, for evidence-based practice as well. And then, like it says there, this is meant to provide some clarity in a very murky field. Google can be a very dangerous place when it comes to concussions. So can, you know, a lot of hearsay from friends, hearsay from different healthcare practitioners that maybe aren't as well informed. So hopefully this evidence-based information can provide a little bit more clarity there. And then hopefully we'll give you guys a few strategies for self-management as well. Again, everything in these lectures may not cover everything that you're feeling, and it may not apply directly to you, but generally this will apply to most concussion patients, or, you know, if you have friends or family members who have experienced concussion type injuries as well. The topics covered. So tonight I will be talking about Concussion 101. Okay, and basically this is a general overview of what a concussion is, what the latest research and theories say about concussion, and some of the epidemiology or the statistics behind concussion as well. I will also be presenting at a later date on nutrition and exercise and how that can relate to concussion. There will be another presentation on pacing, planning, and fatigue management, all very important aspects of concussion management. And then another lecture on self-advocacy and other resources that may be pertinent for any sort of concussion patient. Okay? There will be a variety of speakers and a variety of perspectives. So I will be doing 2 of them. And I am a evidence-based chiropractor. I know sometimes the chiropractic world gets a little bit of a bad rap, but there are many good ones out there that are based in science and in research. And I have done additional training in concussion management. And I was actually just speaking to Ryan about myself, and I have just started my Master's of Rehabilitation Science as well. So I like to think that I'm grounded in science. And so I think I'm very evidence-based. There is another speaker that you will be having, and she is an occupational therapist, and then a third speaker who is a social worker. So we're getting a bunch of different perspectives, the physical realm and some of the psycho-emotional realm and the cognitive realm as well. There will be 4 sessions Monday evenings, and they're approximately 1.5 hours with a break. So I'm going to speak for about 40 minutes or so. We'll take just a 5-minute break, and then we'll get back at it with question and answer period at the end there. And then I just want to set a few ground rules and some guidelines. So the purpose of this group is purely educational. Okay, so this will not apply to everybody's individual experience. This is, again, what the research says and what the general concussion patient has found through their experience. Everybody's going to experience these injuries in far different ways, and so they won't be very specific to you, but feel free to ask, and I'll see if I can answer some questions for you. This is not a space for diagnosis or treatment, though, okay? So diagnosis and treatment should be made by qualified healthcare practitioners in person, okay? This is, again, just purely educational. Let's try and be constructive and not destructive. So this probably applies more so when we're in person in a group setting. But you know, again, people experience things in far different ways. So let's not try to bring anybody down, and just appreciate the fact that we're all individualistic. And then also, this is very confidential and private space, so we won't be sharing any details outside of this. All right. Oh, actually, okay. So before I get into that, I'm just going to explain a little bit about myself. So like I said, my name is Shawn, and I am a chiropractor. So my healthcare journey started when I was a little bit younger, and I was a rugby player. So very physical sport. Took a few knocks to the head and a few knocks to the rest of my body as well. And was always, you know, visiting a physiotherapist or a chiropractor for treatment and care. And so that led to me going to the University of Western Ontario, and I took my first degree there in kinesiology. Continued to play rugby, took a few more knocks, and then after finishing up there, I worked for 2 years as a kinesiologist, basically putting people through rehabilitation plans. At that point, I realized I wanted to do a little bit more, so I went to chiropractic school, did another 4 years of school there, graduated with my doctorate of chiropractic, and then that was in 2016. So I've been working since then, full-time in practice. And then, like I said, I just started my Master's of Rehab Science at McMaster. I've taken a few additional courses in concussion management care. I've also done medical acupuncture training, as well as a few different functional capacity assessments and things like that. I have had a few concussions in the past, probably more than were actually diagnosed, so I can relate to a lot of what you or your friends or family are going through. So hopefully I can give you my perspective on that as well. All right, so let's get into the nitty gritty here. So as we go through the presentation, I want you to keep these questions in mind, because at the end of this, we're going to go through these questions, and hopefully you'll have an answer for these as this wraps up. So number one, do you have to be hit in the head to have a concussion? Number two, do you need to have loss of consciousness? Number three, do concussions show up on imaging such as X-rays, CT scans, or MRIs? Number four, is there a blood test to confirm a concussion? And number five, can a helmet or a mouth guard prevent a concussion? Okay, so some of you may know the answers to these already, but if you don't, then stay tuned. So let's look at some stats first. These numbers are from a year ago, so they may change, but actually, you know what, they may have been decreased now due to COVID and people not experiencing a lot of these things recently. But in any event, so there's approximately, MVA stands for motor vehicle accident. There's approximately 240,000 a year, and 1 in 61 results in a concussion. So fairly high rate there. And these are the diagnosed concussions. So there may also be ones that are undiagnosed. Workplace stats. So out of every 100,000 male workers, there's almost 20 concussions diagnosed. Returning veterans of war, about 15% of them experience or have experienced a concussion. And then SRC in that last bullet there stands for sports-related concussions. So there's an estimated 3.8 million sports-related concussions a year. And this is an American stat, that puts a total burden of almost $56 billion on the healthcare system. So that's not all directly related to the concussion, but things like medications and also loss of work time and loss of earnings and things like that. 10% of all athletes in a contact sport will experience concussion, which is a fairly high number. And we'll see in a later slide that contact sports may not be the typical ones you think of. Reported versus actual numbers is a very interesting thing to talk about as well. So there's something that is called the culture of sport. And the culture of sport is essentially the idea that we try to race back to our sport, or we hide the fact that we have a concussion or a head injury. This is very prominent in things like high-level sport, semi-pro or collegiate sport or actual pro sport as well. And the reason being is that, if you are unable to fulfill your duties in your sport, the team will often move on from you and find someone who will. And so if that is your livelihood and that is your paycheck, then oftentimes, if you're out of a job, you don't make any money. So athletes often hide the fact that they have injuries just so that they can get back to sports and they're not out of a job. So this is where the reported versus the actual numbers may vary. And actually, there's another great stat for you there. More than 50% of concussions are never reported. That may be due to what we were just talking about, the culture of sport, or it may be due to the fact that, maybe the athlete or the team or the trainers aren't very familiar with the signs of concussion as well. And so they may not recognize the injury. So highest concussion rates in sport. So you have your typical ones there. So football, rugby, hockey, very highly physical sports. But then you get ones like lacrosse. And yes, it's a physical sport and there is some contact, but not as much as the first three. And soccer is always a very interesting one, I find, because the rates of concussion in soccer are actually fairly high, especially in women's and in girls soccer. And that's partially due to the repetitive impact from heading a ball, especially in cold weather when the ball becomes very hard, but also due to athletes going up to head the ball, challenge for the ball, and then knocking heads or taking an elbow to the head as well. So that contributes to the high rates in a sport like soccer. If we look at ages 10 to 18, I found this stat to be very interesting, that emergency room visits for sport-related head injury, 39% of them were diagnosed as concussion, and an additional 24% were possibly concussion. Okay, so quick math here, that's 63% have potentially a concussion with any sort of head injury related to sports. Especially in the ages of 10 to 18, those are crucial developmental years for youth. And the last thing you want is any sort of concussive type injury that can impact development and remove you from things like school, things like social settings and work and sport, and could potentially result in higher rates of stress or anxiety as well. All right, so what is a concussion? We're going to be talking about this Berlin consensus statement that you can see referenced at the top. So the CISG is a concussion in sport group. And basically what the CISG is they are the leading researchers from around the world. Every 4 years, they come together and they bring about all their latest research and all their latest thoughts and ideas on concussion. And they kind of go at it back and forth, discussing and figuring out what makes sense, what doesn't make sense. And they come together and they put this consensus statement together. So the last one was done in 2016, and then it was published in 2017. So meaning that there will be a new one coming out next year. But this is kind of the seminal gold standard paper that we use for concussion, okay? So in this paper, they came up with 5 different statements that contribute to what a concussion actually is. So we're going to talk about those. It's a little bit wordy, but I will explain them for you, okay? So the first top point there, so this is directly from the paper as well. Concussion is a traumatic brain injury induced by biomechanical forces, okay? So movement forces. Several common features that may be utilized in clinically defining the nature of a concussive head injury include, and now we're going to go through each of these 5. So it may be caused either by a direct blow to the head, face, neck, or elsewhere on the body with an impulsive force transmitted to the head. So you get hit to the head pretty hard, the face, the neck, anywhere in that kind of upper region, yeah, it can result in concussion. But also, if you are hit elsewhere in the body with enough force that it causes a whipping-like motion or an impulsive force to the head, that can also cause a concussion. Okay, so you're hit hard enough in the abdomen and it flings your head from one side to the other, that can result in a concussion. And we'll get into why a little bit later, but that's important to know. It typically results in the rapid onset of short-lived impairments of neurological function that resolves spontaneously. So typically in your very classic concussion, the onset of symptoms are very fast and they're usually short-lived, okay? That resolve spontaneously. This isn't the case for everybody, I realize that, but in kind of your, if you can see me, I'm doing air quotes, run-of-the-mill concussion, they are very short-lived and they can resolve spontaneously. However, in some cases, signs and symptoms evolve over a number of minutes to hours, so they can change. Just because this is a very common presentation we see in practice, just because somebody was in a car accident, they feel fine that day, doesn't mean that the next day or the day after they won't present with some concussion type symptoms, okay? Number 3, so it may result in neuropathological changes, but the acute clinical signs and symptoms largely reflect a functional disturbance rather than a structural injury. And as such, no abnormality is seen on standard structural neuroimaging studies. This is a huge point, okay? So can a concussion result in something that would show up on imaging studies? Of course, if you're hit hard enough in the head, you may fracture your skull and that would show up on an x-ray. But the acute clinical signs and symptoms of a concussion largely reflect a functional disturbance rather than a structural injury. So a fracture or something that affects the structure of your body would show up on imaging. A functional disturbance, which can be things like an imbalance in neurochemicals or an energy deficit, those do not show up on standard structural neuroimaging studies, okay? Super important, because oftentimes what happens is a patient will go to their GP or will go to the hospital. They will be given a CT scan or an MRI and nothing shows up on them. And then the doctor will say, oh, you don't have a concussion. There's nothing on the imaging. But again, and I'm hammering this home because it's super important, a concussion is a functional injury, not a structural injury. It will not show up on standard neuroimaging studies. Number 4, results in a range of clinical signs and symptoms that may or may not involve loss of consciousness. Okay, so the symptoms can be wide and varied. We'll go into them in a second, but you don't have to lose consciousness to have a concussion. This was another very important point, because oftentimes, before all this concussion research came out, that was kind of the gold standard question. You go see your doctor after an injury and they would say, did you lose consciousness? Did you black out? And most people would say no. And they said, oh, okay, then you didn't have a concussion. That's not the case anymore. We realize now that concussions can result without having a loss of consciousness. Resolution of the clinical and cognitive features typically follows a sequential course. However, in some cases, symptoms may be prolonged. So again, this is kind of hammering home the fact that typically we understand how concussions will present, how long they will take, and again, in your run-of-the-mill concussion, how long recovery takes. However, that is not always the case, and there's a number of different factors that go into that. And then finally, the clinical signs and symptoms cannot be explained by any drug, alcohol, or medication use, or any other injuries such as cervical spine injuries or neck injuries, peripheral vestibular dysfunction, or any other comorbidities, psychological factors, or coexisting medical conditions. So basically, that the signs and symptoms that you're experiencing can't be explained by any other source. Okay, and so I tried to put this in a nice consent statement here. So simply put, a concussion is a mild injury of the brain, although not always felt as mild. It is considered a mild injury of the brain caused by a physical force that results in mainly short-term, sometimes long-term functional impairments and is unexplained by other mechanisms of injury. Okay, I'm going to read that one more time. A concussion is a mild injury of the brain caused by a physical force that results in mainly short-term, sometimes long-term functional impairments and is unexplained by other mechanisms of injury. Okay, a few hints there for those questions we started with at the beginning of the presentation here. Okay, so let's pivot a little bit. We're going to do a little bit of anatomy, okay? And we're not going to get too sciencey here, but we need to know the basics of the anatomy here to understand how a concussion happens and how it takes place, okay? So this is a brain. You can see the picture in the top left corner shows the actual brain structure like we're used to seeing. The black square around the brain indicates we've taken a cross section of this brain. So essentially we've cut it in half and now we're looking through the middle of it, okay? The reason I wanted to bring this about is that I want you to pay attention to what the gray matter and the white matter are, okay? So the gray matter has they differ from each other by having a specific protein. One has the protein and one doesn't. And because one has the protein, they vary in density, okay? And the density of the two structures is very important here, okay? The ventricle is a space within the brain that is typically fluid filled, but that's not important for our purposes here. Just gray matter and white matter, two different density parts of the brain. And this is a neuron. So the neuron is the functional unit of the brain, or a brain cell, essentially. Okay, so this is what makes the magic happen in the brain. This is what makes all the function of the brain happen, okay? You can see, if we look at the left side where the nucleus is, that's basically the command center of the neuron. And then we have the axon, or this arm-like structure with axon terminals, which helps to deliver the message. And if we go to the next slide here, these neurons are arranged within our brain from axon to nucleus, all throughout our brain. This is where the information gets passed along basically a path, depending on whatever it is. You know, you want to think about something. It starts in a specific spot in your brain, and then it travels through these neurons further and further. All right, so we're going to talk about the theories of how concussion happens, okay? So again, these are theories. They're not concrete, but this is how we believe these concussions or these injuries do happen. So when I was in school, in my undergrad, I graduated in 2010. I had learned about the first theory there, which is the coup contra coup theory, okay? And it's I always find it very interesting with concussion research, how much and how quickly things change. And I'll just go into a quick little rant, I guess, here. But, you know, 10, 12, 15 years ago, people knew of concussions and had heard of concussions, but really there wasn't much out there as far as literature or, recognition of concussion. And then if anybody is a hockey fan out there, a player named Sidney Crosby had a fairly significant concussion. And it seemed like that was almost the catalyst for a lot of money and funding to be put into concussion research. And, it's unfortunate that it takes a high-priced asset like a professional athlete to kind of spur that change. But it does help general healthcare because then that information is able to be disseminated amongst everyone else. But the interesting thing I find, and I'm going to relate this back here, is that, the coup contra coup theory, like I said, I graduated in 2010, and that was the accepted theory. And in only this paper, this Berlin consensus paper came out in 2016, 2017. In only 6 or 7 short years, they've disproven that. And now they've moved on to number 2, the acceleration deceleration theory. Okay, so let's just talk about the coup contra coup theory, is because I think a lot of people still believe that this is what is happening. So the coup contra coup theory basically is the idea that your skull is a hard, very solid piece of bone, and your brain is essentially this jelly that's inside. Okay, and so the idea, or the theory, was that an impact would cause your brain to move inside of your skull. It would hit one side of your skull, cause a bruise or a bruise-like injury, and then would whip to the other side of your skull and then potentially bruise the other side as well. This is where the coup contra coup comes from. So the coup is one side, the contra coup is the other side. Can anybody see what the issue is with this if there was a brain bruise? The problem with that is that if there was actually bruising, it would show up on imaging, right? If there was actual structural damage to the brain caused, when we took an MRI, when we took a CT scan, we would be able to see that. But like we said earlier, the concussion injury, is a functional injury, and therefore it won't show up on those types of neuroimaging studies. So we have since moved on to number 2, which is the acceleration deceleration theory. And this is why I wanted to go over some of that anatomy at first, because we need to know that the brain matter densities between the gray and the white matter, like we looked at, they have different densities, right? And so the important part of that is that things with different densities will accelerate and decelerate, or essentially move at different rates. So the idea now is that there's a stretch and shear mechanism. So when we are injured, what happens is that the white matter and the gray matter accelerate or move at different rates, meaning that we are opening we're moving these different structures at different rates. They are causing neurochemical channels to open up at different rates. And then we end up with this functional injury, right? The important thing here is to remember that a stretch and shear doesn't mean that we're tearing or shearing or opening up or tearing any of the structure of the brain. It's just called a stretch and shear mechanism, which causes these neurochemical channels to open, which causes a improper release of some of the neurochemicals. Okay, and we'll get into some of that in a little bit. There's essentially 2 phases to a concussion. Okay, the first phase is what's called the excitatory phase, and then the second phase is called spreading depression. And we're going to talk about those here. So excitatory phase is typically the first 15 minutes of the injury. Okay, the stretch and shearing of the 2 different densities of brain matter causes huge neuron activations. So those cells that we looked at, they become activated with that stretching and shearing. And depending on where in the brain the neurons become activated, the response is very different. I like to liken this to something like you are turning every switch on at once, okay, in your brain. So this is where we see almost like your classic concussion signs when somebody gets hit in hockey or hit in football, or, is in a car accident and hits their head off the steering wheel. This is when you start to see, or when patients start to experience the idea of seeing stars, or, in the old cartoons when you'd see these little Tweety birds going around somebody's head. You may experience a loss of consciousness, speaking gibberish, or using inappropriate verbiage when you're speaking to somebody. Inappropriate emotional responses is something that we see very often. Somebody's just been in a car accident and they get out of their car and they're laughing, right? It's again, depending on where you experience this injury, you can have some of these, or you can have one or two, a combination of a whole bunch of different ones. The fencer's response is something that you may see in some sports, where if somebody gets hit pretty forcefully and they lose consciousness, they almost have a rigidity of their body, and one of their arms raises, or people often mistake it for a seizure, but in reality, this is a response to the injury. I did have a couple of videos here, but I'm not going to show you, just because it sometimes can be tough to look at. If you want to see them, I can flip you the links later, or just YouTube fencer's response, and it will come up. Okay, so the first stage of a concussion is the excitatory phase. Everything goes on all at once, and there's a huge influx of energy being used. Okay. Second phase is something called spreading depression. Okay, and this is when you get almost I know I use classic concussion symptoms for the first stage, but this is kind of your typical concussion patient after a few days. Okay, this phase can typically last from 22 to 30 days, and this is in rat models and rat studies. So the applicability to humans can vary, but this is what we've seen in previous studies. And this is the spreading depression is an energy crisis, essentially. So we have asked, we essentially, the first phase turns on all the lights. Okay, we need to close all those channels that were opened by the stretch and shear mechanism. It takes a lot of energy to stop the effects of the excitatory phase. This causes a neurochemical or a neuroion imbalance, and then that disrupts energy production. And essentially, this is what the remaining symptoms are from. So there's increased energy demand, but we're not producing it fast enough. And this is why it says there are, energy crisis. And this is when we start to experience things like that persistent low-grade headache, photo or phonosensitivity, so light or sound sensitivity, being super tired and fatigued, and the exertion levels don't match our fatigue levels, right? You might be super fatigued from just dusting your small little apartment, and then you feel like you need to take a 4-hour nap. Things like a heightened emotional state, increased irritability and anxiousness, moodiness. I'm sure anybody with a head injury has experienced that. Cognitive issues, decreased attention or concentration, poor memory, this whole idea of mental fog. Tinnitus, which is the ringing in our ears, and sleep disturbances. These are all super common things to experience, and this is usually due to the energy crisis. All right, we're going to take a break just for 5 minutes or so. Just wanted to again hammer home, functional injury, not structural. Okay. Break time. So let's just take 2 minutes here. Actually, I'm just going to check my clock. 6:38. So yeah, I'm just going to grab some water. Let's start in 2 minutes. 6:40, we'll start again. Okay. Alrighty, so just a quick short break. I just needed a small drink of water. So let's move on here. Hopefully this is all making sense. Again, we can take some questions at the end. Yeah, we'll move on here. Okay, so I think another area that we need to look at anytime there is a concussion is the cervical spine. Obviously, being a chiropractor and being a bit of a back specialist, this is an area that I always address. But I have worked with a sports MD in the past, and he said the most overlooked area of any sort of concussion injury is the neck. And the important thing to remember about the neck is what we're going to talk about here, the forces of the injuries. Okay, so through some pretty gruesome studies through animal models, they were able to figure out that concussion injuries typically will result from between 70 to 120 G's of force. Okay, or that's basically force times the force of gravity is what a G is. So 70 to 120 times the force of gravity will typically result in a concussion. Whiplash injury of the neck will usually result in about 4.5 G's. Okay, so what does that mean? That, in 99.99% of concussion type injuries, you will also experience whiplash. Okay, and I have yet to see a patient who has come in with a concussion and has not also experienced whiplash as well. Okay. Cervical whiplash, mechanism of injury. So typically the idea is this whipping motion, right? We've all seen the crash test dummies in the car commercials where the head will whip forward and whip backwards, right? Which is pretty similar to that idea of that coup contra coup that we had talked about. I know that's not the accepted theory right now, but that is still the mechanism of movement in any sort of stretch and shear injury even. And what the whiplash usually leads to is a strain or sprain injury. Okay, so strain, we do strain muscles and we sprain joints. So this is both a muscle and a joint injury. Okay, there's a whole bunch of fancy Latin words there: suboccipital, splenius capitis, trapezius, SCM, scalenes. Those are names of muscles that we're going to talk about in a second, but typically a whiplash injury will cause a strain to those muscles as well as the cervical spine or the neck joints. It can also lead to CNS dysfunction, and CNS is the central nervous system. The central nervous system is your brain and your spinal cord. Your peripheral nervous system is the nerves that leave your spinal cord and go to your hands and your feet. But a whiplash injury can cause central nervous system dysfunction, or the nerves of more of our central body. And specifically something called the cervical sympathetic ganglion, which we'll talk about in a minute. So those fancy Latin words, like I said, reference muscles. Okay, and there were some pretty smart researchers out there named Travell and Simons who came up with the idea of trigger points or referred pain. So referred pain is essentially dysfunction of a muscle that causes pain at a nearby location. So you may feel the pain somewhere, but often it's not where you're looking, or where the pain actually is, where the dysfunction is. So if we look at the picture on the left there, these pictures are from their textbook. These suboccipital muscles are a group of 4 small muscles on either side of your neck, right at the base of your skull and the top of your neck region. So the X marks the spot as far as where the dysfunction is, and the red actually is where, through their studies and through their research, people have experienced the pain and the discomfort. Okay, so the suboccipitals forms almost like a question mark pattern wrapping around the ear and up towards the eye's temple region. Okay, splenius capitis, another muscle at the base of the neck, base of the skull, top of the neck, and people often experience the pain at the top of the skull, on top of their head. SCM, or sternocleidomastoid. This is the muscle at the front of our neck. oftentimes felt as pain at the forehead, wrapping around the eyes, sometimes at the chin. Trapezius, a big muscle on the top of our shoulders, pain up through the neck, round the side of the head, the jaw, right behind the eye. The reason I wanted to bring these up was these are often the spots that a lot of concussion patients complain about where their headaches are or where they experience pain, right? Let's just go back a page here. Side of the head, temple region, top of the head, around the eyes, right? Back of the skull, forehead. I'm sure, if you've experienced concussion in the past and that persistent headache that we're feeling, you've probably felt these headaches, very similar to what these pictures are showing. And now I'm not saying that these headaches are completely as a result of just muscular dysfunction, but will they play a role? Most definitely, for sure, right? And this is why it's very important to look at the neck, because you can do all the, quote unquote, concussion specific rehab or treatment that you want to do. But if you're not addressing the neck, then those dysfunctions will still persist. We're going to talk about that cervical sympathetic ganglion that I alluded to earlier. This can get a little too kind of sciencey specific, but I just wanted to bring your attention to this because this is, again, another important reason for why we need to assess the neck. Okay, so a ganglia is a grouping of nerve cells. Okay, and these ones here are intentional. You may have heard of things like ganglion cysts before. They're very common in the wrist. This is not like that. A ganglion cyst is a dysfunctional thing. These ganglia, these sympathetic ganglia they're supposed to be there. We all have these. And so a ganglia is a grouping of nerve cells that helps to control higher level functions of the CNS, or your nervous system. So there's three major ones in the neck. There's a few other ones, but the three major ones are the superior, or the uppermost, the middle, and the inferior ganglion. And I want you just to look here where the red star is on the picture. That's where the superior cervical ganglion is. Okay, so it's located in numbers 2 and 3 vertebrae of the neck. Again, this is that uppermost region of the neck, kind of below the skull, where a lot of that muscular dysfunction that we just saw, where those X's were. So the combination of the muscular injuries, the whiplash injuries, can also affect these ganglion. And if we look at what this superior ganglion does, or this one here, the red X, it kind of relates to what many concussion patients feel. So muscle function, sure, but sleep-wake cycle. Concussion patients often will talk about how they have very restless sleep, or they feel like they can't fall asleep for hours, and then they end up falling asleep at 4 a.m., sleep until noon, and then their sleep-wake cycle is so disrupted, right? Pupil eye function. So it can help, or the ganglia will play a role in our eyes and the dilation of our pupils, right? This relates to things like photosensitivity or light sensitivity. Our balance and vestibular system. Almost every concussion patient I see will come in complaining about they have increased clumsiness, or they feel like they're walking on a mattress, or they've just gotten off a ship, right? And this can play a role in that system that helps you balance. To a lesser degree, potentially CSF production, which is cerebrospinal fluid production. There's some emerging research on that, but that's a little bit of a lesser one, so don't worry about that one too much. Okay, so I hope all that is making sense so far. We just have a couple, actually, I believe this is the last one we're going to talk about, the last item we're going to talk about, and this is PCS, or Post-Concussive Syndrome. So we've talked about kind of your, quote unquote, typical concussion so far, your acute concussion, and how they happen, signs and symptoms, and typically that they will last 22 to 30 days, okay? So if we look here, this is from the International Classification of Diagnosis book, and these are the criteria that the book states that you have to have in order to have post-concussive syndrome or prolonged concussive symptoms. You need to have at least 3 of the following symptoms 4 weeks post-injury. So this matches up very well with the 22 to 30 day timeline. So headache, fatigue, dizziness, memory problems, irritability, sleep issues, concentration issues, stress emotional issues. I'm sure, you know, if we've had a concussion, we can say, yeah, I've had all of these. If you have PCS, you can say, yep, I've had all these for more than 4 weeks. That's how you actually will diagnose PCS. Okay. The exact pathology of PCS is still unknown. Again, there's a few theories that we'll just go through quickly, but we can't pinpoint it to one exact thing. And the reason being is that everybody sort of experiences it for different reasons, right? I always see patients come in and they always want the one reason why they're experiencing something. But in reality, we're, you know, high level functioning creatures, and it's never as simple as it just being one thing that is causing this PCS. It's typically a combination of a few different things, and we'll get into those in a second. 30% of all concussion patients will experience post-concussive symptoms, so that is a fairly significant chunk. So we need to know how to diagnose it and how to address it as well. And there's 6 theories of how it happens. Okay? I mean, like I said, people always want one of these theories to apply to them, but it's usually a combination of a couple. So the first one, again, these are based off some rat models, but pretty convincing evidence. Number 1 is altered blood flow. So immediately after a concussion, there's up to 50% reduction in brain blood flow or cerebrovascular flow. Okay. This is typically seen in the patients with symptoms that flare up or get worse when they have increased their cardiovascular output, you know, are doing a set of stairs or have gone on a jog or a bike ride. Anytime you start to get the heart pumping, if you feel like your symptoms get worse, then this could be a component of it. Okay, we'll talk a little bit more about that when we get into exercise, because this also gives us a bit of a direction as far as treatment and exercise prescription and how we use physical activity as a treatment tool. Number 2 is a combo here. So metabolic, or those ongoing energy deficits that we talked about. ATP is adenosine triphosphate, which is our body's energy source. Remember we were talking about how it costs a lot of energy to turn all the lights off. Well, some of us are just not as efficient as others at producing the ATP and overcoming that energy deficit. So it can be due to that. It can also be due to a cyclic process of inflammation. So the injury can cause, the initial injury can cause some inflammatory markers to present. That inflammation may cause continual injury, which then causes more inflammation, which causes continual injury, and you just get caught in this cyclic process. Visual or vestibular dysfunction. So 70% of concussion patients will experience vision problems or vestibular balance issues, right? And this is sometimes a forgotten area of care when somebody's dealing with a concussion. It's important that your healthcare provider assesses your visual capacity, assesses your vestibular capacity, because again, if you're only treating certain aspects of your injury, you'll hit a plateau with symptoms still present. Okay, visual processing, so your ability to see something and actually understand what you're looking at. Proprioception is your body's awareness of itself in space, where your head is in space, you know, how you're actually moving. And then balance vestibular issues, so things like, again, just balance or being increasingly clumsy. Cervical spine dysfunction or neck dysfunction, as we discussed, if we don't address that, it can cause prolonged duration of post-concussive syndrome. Facial pain is something that concussive patients often will report. There is a specific nerve that comes from our brain and supplies the sensation to our face. It's called the trigeminal nerve. And that actually does interact with our C-spine or cervical spine. So that can be a source of it. Psychological. So there's always, any injury really includes a psychological component. I know when I was injured playing rugby, concussion, I was a little hesitant to get back on the field, right? And I was healed physically, but psychologically, there's still a hurdle to overcome. And there's actually some significant research out there that says that if you have high levels of anxiety or depression previous to a concussive injury, that puts you at a higher risk of developing post-concussive syndrome. So it could be that we're just not as good at coping with the injury as other people who don't have pre-existing levels of anxiety or depression. The good old days bias is one that I like to bring up to every patient that I see. And that's because we typically are pretty hard on ourselves. So I'll give you an example of what the good old days bias is. People always tell me that, oh, I've misplaced my phone. And as an example. And the good old days bias says this: if we misplace our phone prior to having a concussion, we would just attribute it to, oh, I just misplaced it. You know, I found it a couple hours later. No harm, no foul. But when people experience a concussion injury and they do the same thing, they misplace their phone, they say, oh, I never would have done this before my injury. So is that true? Potentially, but it's also not explicitly true that you're only misplacing it because of your injury, okay? It's important to not be too hard on ourselves, right? It's important not to ignore any of the cognitive issues that somebody's experiencing, but it's also important to not be too hard on ourselves because, like I said, there's already a psychological component to this issue. We don't need to pile on there, okay? Fears, distress, worry, media influence, and this is kind of that murkiness that I spoke about right at the beginning. There's a lot of misinformation out there. There's a lot of hearsay, you know, through friends of friends. The media has a huge influence on us as well. Social media is great, but it's also can be pose a bit of a dilemma for us as well. So it's important that we don't pile on because this can really increase our risk of developing post-concussive syndrome. And then again, to a lesser extent here, the endocrine system, which is mainly our hormonal system, there is very minimal research on that contributing to post-concussive syndrome, but there is research nonetheless. And I don't really get into too much of that because that's a little bit outside my scope. Oh, second impact syndrome. So finally, last topic here. Second impact syndrome is when you have another concussive injury within the vulnerable period. Okay, so the vulnerable period, like we said earlier, typically your concussion will last 22 to 30 days. Okay, if you sustain another injury within that time frame, you may be apt to experience, cumulative concussion symptoms and something called second impact syndrome, even at modest impacts. Okay, so it almost lowers the threshold required for injury to happen. This is very infamously noted with Rowan Stringer, who was the young rugby player. She, I believe she was out of Ottawa, and now that we've developed Rowan's Law, she returned to sport too early. She suffered another head injury, and unfortunately she passed, but this is what she was subsequently diagnosed with. The inherent problem is that, again, very typical concussion symptoms will last between 7 to 10 days, especially in young people, because young people are very resilient and they bounce back very quickly. So if your symptoms last 7 to 10 days, but the vulnerable period is 22 to 30 days, there is a period of time where symptoms don't match your vulnerability. So oftentimes these athletes or these people will get cleared to return to play, return to work, whatever it may be. When they are still in a vulnerable state, they suffer a injury at a modest impact, and then that can cause this syndrome to take place. The second impact syndrome doesn't always result in mortality, but it can cause somebody to experience exacerbation or prolonging of their symptoms and can eventually lead to post-concussive syndrome as well. All right. So we went over these at the beginning. Hopefully everybody has an answer to them now. Let's go through them again, and then I'll just give you a quick blurb on each. So do you have to be hit in the head to have a concussion? So we know from the Berlin consensus statement that no, you don't have to be hit in the head to have a concussion. If you are hit in the rest of your body with enough force that it causes impulsive force to be transmitted to the head, that can also result in a concussion. Okay. Do you need to have loss of consciousness? So no, you don't have to have loss of consciousness. Actually, I didn't include this in there, but I believe the stat is 95% of all concussive injuries don't have loss of consciousness. So the vast majority of concussions do not have loss of consciousness. So that is not the make or break question for concussion injury. Do concussions show up on an X-ray, CT, or an MRI? And the answer is no. So we know that these are structural imaging modalities. X-rays, CT, and MRIs will show structural issues or damage. And we also know now that concussions are not a structural injury. They are a functional injury, okay? So they will not show up on X-rays, CTs, or MRIs. And actually, as I'm looking here, we didn't cover these last two within the presentation because I kind of pared it down a little bit, but I can just talk briefly on them here. Is there a blood test to confirm a concussion? So there was some news, I believe it was maybe 2 or 3 years ago, there was actually a paper in the Toronto Star about there was this novel new way of diagnosing concussion based upon something called CRP, or C-reactive protein, in our blood. Okay, and basically it's a marker of inflammation. So they were touting it as, a new way of confirming whether you had a concussion based on you having inflammation in your blood. Which, sure, we talked about inflammation being a potential marker of concussion and PCS. But the problem with that is that it's not specific to concussion, right? You can have inflammation from a whole host of other conditions or diagnoses, or, maybe you're sick. Maybe you have the flu, or you have a cold, or whatever it may be, some sort of inflammatory systemic issue. So if you had that going on, experienced a potential concussion injury, and someone took your blood, it would show up as positive for a C-reactive protein. And according to this paper, it would say, yes, it would be a positive concussion test, but in reality, that would be a false positive because it would be looking at something else. So to this date, there are no blood tests to confirm concussions. I believe they are working on them, but nothing concrete as of yet. And then last question here, this is always a good one. Can a helmet or a mouth guard prevent a concussion? I know when I was playing rugby, my mom would always yell at me, make sure you have your mouth guard. We always talk about the importance of using a helmet while riding a bike or skateboard for not only children, but people in general. And so a helmet or a mouth guard cannot prevent a concussion. Okay, and this goes back to the stretch and shear idea of concussions. No matter if you're wearing a helmet or you're wearing a mouth guard, the amount of force that gets transmitted to your head, to your brain, is the same if you're wearing it or not, right? It's the idea of this acceleration and deceleration of the differing brain matters in your head that cause that stretch and shear mechanism. Now, is it important to wear a helmet or wear a mouth guard? Of course, because it can prevent more sinister issues, such as a fracture of your skull and potential hematoma or brain bleed if you're wearing a helmet. A mouth guard is super important as well because it can help to protect against, breaking or losing teeth, breaking your jaw, things like that. But specific to preventing a concussion, it hasn't been shown to assist with that. Okay. I'm not advocating that you don't wear helmets or you don't wear mouth guards, but just know that it's very unlikely that it would help to prevent a concussion. All right, and so we're going to go into questions. This imaging modality you're looking at right now is what's called a functional MRI. That's actually a picture of the brain, and I find these to be pretty cool looking, so I thought I'd throw a picture on there for you guys. So I'm going to stop sharing my screen here. And so hopefully you guys enjoyed that and got something out of it. I am open to answering any questions, or if anybody has any comments, I can speak to anything. So if you have any questions to ask, you can either throw it into the chat there, or you can put it into the Q&A section. Hopefully I didn't just put you all to sleep. Okay, here is a question. You would like to answer this question live? Yeah. Oh, sorry. Here. Okay. I came in late as I mixed up the time this began. Okay, that's fine. Can your symptoms get worse over time? Yes, symptoms can definitely progress over time, and that is, again, for a number of different factors or reasons, right? Mismanagement or poor management of any sort of injury can cause things to become worse. Exposure to aggravating factors can cause things to get worse. Not proper pacing, not paying attention to your fatigue levels, having improper treatment, too long of a delay to start treatment, predisposition to post-concussive syndrome, like we had talked about at the end there. There's a whole number of different reasons for why your symptoms can progress. So can they get worse over time? Of course. I mean, ideally, we manage things correctly from the beginning, so they don't, though, right? Okay, here's another question. What does it mean on an MRI if you have too much white matter for someone your age? Okay, so an MRI is kind of the gold standard testing or imaging for a lot of different things, and especially the brain. So that, again, this is a little bit outside of my scope of practice. Typically, that would be a neurologist or a radiologist would be able to tell you a little bit more about that. So white matter so if you're talking about white matter in relation to the brain, that is normal tissue. If you're talking about white depositions or white deposits, that can be something related to some sort of neurodegenerative disease. It can be normal, right? It's a little bit more, you need a little bit more information than just too much white matter. You need to know a little bit more about the clinical picture. And it's important to note, and I tell this to a lot of my patients here, that imaging is super helpful. It's a very helpful modality to have because it tells us exactly what's going on. But at the same time, imaging is not perfect. It doesn't always correlate with clinical findings, okay? We treat patients, we don't treat pictures or images, okay? So without me knowing a little bit more about the exact specifics of your case there, I can't tell you a little bit more about that. I had severe whiplash, but other than physio in the beginning, the first 3 months, nothing else was done. I have PCS for 4 years now. Should I be looking at chiropractic assistance? So a lot of people ask me that, should I see a chiropractor or should I see a physiotherapist? I don't have a preference for either. Okay, I'm a chiropractor by trade. I probably don't treat like the typical chiropractor, but that's my designation. My wife's a physiotherapist. Okay, She does a lot of the very same things. And what I would say to that is typically, if you have a very good physio, if you have a very good chiropractor, they are doing many of the same things. Okay, they should be doing many of the same things. So I wouldn't say you have to look at chiropractic assistance specifically. I would say that you need to see somebody who is well versed in concussion management. Okay, here's another question. How can people who live alone get substantial care without exhausting themselves financially? Yeah, and this is always a tricky subject. I am not the best person to answer this question. If you attend a later session with both our occupational therapist and our social worker specifically, she is going to be speaking about self-advocacy. The other thing is, I'm talking a little bit more about the sciencey type stuff here, but reaching out to organizations such as BIST can really help. They have many resources that can help and assist you in having, finding the spots you need to go to for care. Okay. Why is such a debilitating injury considered mild? I have severe PCS and there's nothing mild about it. Yes, I would agree with that. This is just the medical jargon that is used. These TBIs or brain injuries are graded on a mild, moderate, severe scale. Although symptoms and the way you experience PCS can be, very severe, they are still considered a mild to moderate type of brain injury. Severe brain injuries are you would see a little bit more physical deficits as well, and cognitive and psycho-emotional. I was hurt in 2015. I'm still battling with symptoms. I have now been diagnosed with functional neurological disorder. I'm doing a lot of different therapies, just wondering how much longer does this ever get better? I'm just tired. Yeah, it's exhausting feeling this way, and I can appreciate that for sure. Like I said, I had experienced my own concussions to a degree. I was lucky enough that I was properly managed and was able to overcome them. Are there times when I still experience symptoms? Of course, but I know that it can be very exhausting and very frustrating and upsetting to experience these types of injuries for so long. Again, it's tough for me to say specifically on how long, how much people feel symptoms wise. It's just important that you find a healthcare practitioner that can help facilitate the proper care that you need to get. Why do they say PCS resolves itself in 3 to 6 months when in actual fact it can last for years? Yeah, okay. And this is what I was referencing in, if you could have seen me, my quote unquote typical concussions or typical PCS. In perfect kind of settings, we'll call them laboratory settings, these issues can resolve in, a few weeks. They can resolve in a few months for PCS. But in reality, there's a lot of different stressors in our lives that are not always accounted for. So we're people, we experience, things on the daily, and those would all factor into our recovery rates. Again, in a textbook, it would say, yes, 3 to 6 months, but we're not all textbook, right? It would be the same thing, for an ankle injury. In a textbook, an ankle injury should last 4 to 6 weeks if it's a grade 2 moderate ankle sprain. But in reality, we're going to have ups and downs, and there's going to be peaks and valleys, and we won't always follow the natural history timeline that a textbook says. And that's the same thing with the PCS type injury. And it's even worse with PCS just because it is such a complex injury, right? What would make symptoms that went away come back after a year? Again, a little tough for me to answer specifically. I'll give you, and I'm sorry for a lot of these answers being very general, but that's just the nature of this format here. What would make symptoms that went away come back after a year? So in the absence of actually having another injury, it could be that they, maybe they weren't fully gone. Maybe they had gotten to a point where you had just become accustomed to them, and that was, what you had thought was normal. The other thing that can often play a role in something like that is stress and anxiety. I like to look at stress as sort of a magnifying glass, that you have, a condition or an injury, and then that stress magnifier can, exacerbate it or kind of blow it out of proportion. And in a year like this year, we have all our different stresses that are related to COVID and life as it has been over the past 6 months, and that can play a role in that as well, right? So it's a number of different things that could make symptoms come back. Maybe a trigger, right? I've had a patient that we discharged because he had essentially recovered and his injury resolved. Then he went onto a cruise, got onto a little Zodiac boat to go to land, and found that just caused a huge flare up of his vestibular symptoms, sorry, dizziness, imbalance, that kind of thing. And so we had to bring him back and treat him specifically for that. So sometimes there are triggers that can occur that way. If one theory for PCS is blood flow issues, how does one explore this more? SPECT scans, functional MRIs, what can be done? That's a great question. And I am going to talk about that actually in exercise, the exercise lecture. There's a test, there's a number of different tests. The one test that I like to use and has great research behind it is called the Buffalo Concussion Treadmill Test. Okay. And it is a gradual, increasingly tough exertional test. Sorry, it's an exertional test that looks at increasing your cardiovascular output under controlled conditions, so that we can, first of all, determine if blood flow issues are the origin or one of the origins of your PCS symptoms. And then from there, if it is determined that they are one of the origins, then we can make recommendations as far as how we use exercise and how we use physical activity as treatment for that. So sorry to leave you hanging there, but that is one of the things we're going to look at. Some of the higher level scans, like you said, SPECT scan, functional MRIs, they may show things. There is also something called DTI, which is diffuser tensor imaging, which can potentially show things like that. But again, there's a whole lot of just research being done right now. I would expect a lot of this stuff to come out in the next couple of years or so, and probably sooner, hopefully. Follow-up questions to symptoms getting worse. Can they get better, or is there a time limit to when a certain part of the brain can be healed? Missing my old high-functioning self. I'm upset I got the time of this webinar wrong. So looking forward to it. Old Sheena never would have missed something this important. So this is a great example, and not to put you on the spot here, this is a great example of the good old days bias, right? Don't be so hard on yourself. If we're being honest, I was almost mixed up with the time here as well. So let's keep that in mind as well. So can your symptoms get better, or is there a time limit to when a certain part of the brain can be healed? So you can continue to improve, right? And this lies in the theory of what's called neuroplasticity. If anybody has read anything from Norman Doidge, which I believe his book is called The Brain That Healed Itself or Heals Itself, he speaks about the concept of neuroplasticity. There's actually some really, really cool research and new technology coming out that focuses on the idea of neuroplasticity. And I took the course and am trained and have used on a number of patients something called PONS. You may have seen some of the commercials or advertisements, social media stuff on what the PONS treatment is. PONS stands for Portable Neuromodulation Stimulator. And it lies in the theory of neuroplasticity, that your brain is adaptable. You can teach and you can learn. And, you know, sometimes the capacity of that is decreased as things such as, you know, age or other comorbidities take place, but you can, the same way, you know, that you can learn how to speak another language, right? You can pick up these new skills. It gets harder to learn another language as we get older, just because, you know, it's a difficult task and our brains are not as malleable as when we were kids, but you still can do it, right? So yes, things can get better. But the insurance companies follow this line of thinking. They do not believe it lasts longer. Yes, I'm assuming you're speaking about PCS, and insurance companies can be very difficult to deal with. They essentially are a business, right? They're trying to limit the amount of money that they pay out, and, you know, is it always fair? They think so. It can be kind of difficult to reason with, but yeah, that's a battle that we're fighting on our end as well. What are some things to do, eat, avoid to relieve chronic migraines? Great question. And again, it's a little bit difficult without knowing the source of the chronic migraines. So just in general, so I will speak a little bit about this in the nutrition and exercise lecture, but regular exercise is a great one. Okay. Trying to avoid the inflammatory foods, some of the nightshades, things like tomatoes and spinach and kale, and some of the darker ones. Anything that can promote inflammation in your diet is something that could generally help with migraines. Screen time is often one that people report as a trigger for migraines. Chocolate, red wine, all the good things. But again, it's very difficult without me actually knowing a little bit about your case or assessing you, right? Because I've seen patients that have come and seen me and you know, they've had migraines for 3 or 4 years, and it's as a result of their neck, right? So I treat their neck and then they feel better. Or they've had migraines because their visual system is a little bit dysfunctional after an injury. So we do some visual rehab, and that seems to do the trick for them. There's a whole lot of different origins of these types of injuries, and so it's difficult for me to give you a concrete answer. Like I said, I will be going into some more specifics in that lecture when we talk about that in 2 weeks' time. All right, everyone. I do want to apologize because I know those are some wishy-washy answers. We are all very individualistic, and we all have, you know, very specific nuances to all of our stories and our injury histories and things like that. So it's tough for me to really give you concrete answers, but I hope that you got some good, solid information out of this. Like I said, I wanted to give you some of the evidence behind what concussions are, what they actually are, how we believe they happen currently. Just because, like I said, a lot of misinformation out there. And I think if you can understand the injury first, that goes a long way to understanding why you're feeling such a way. Okay, so stay tuned for the next couple of presentations on the next 3 Mondays, because they might be a little bit more applicable for you, and some of those takeaways as far as strategies and you know, things that you can actually try for yourself at home. Okay, I hope everybody enjoyed. Like Ryan said, this will be uploaded. It was recorded, should be uploaded on the website within the next few days. All right, take care, have a great night, and I'll see you guys in 2 weeks.